and the tens of thousands of doctors, nurses, and other healthcare professionals who support this legislation. Let me thank the 15 Senate co-sponsors that we have on this bill, and the 122 members of the House who support very similar legislation. And mostly, let me thank the American people who by the millions understand, as I do, that our current healthcare system is dysfunctional, it is extraordinarily wasteful and expensive, and it is cruel. The American people understand, as I do, that healthcare is a human right and not a privilege, and that we must end the international embarrassment of our great country being the only major nation on earth that does not guarantee healthcare as a human right to all of its people. It is not acceptable to me, nor to the American people, that over 70 million Americans today are either uninsured or underinsured. As we speak, right now, this moment, there are millions of people in our country who would like to go to a doctor, who have to go to the doctor, but simply cannot afford to do so. This is unacceptable. This is un-American. And this cannot be allowed to happen in the wealthiest country on earth. Bottom line is that your health and your longevity, how long you live, should not be a factor of how much money you have. Healthcare is a human right that all Americans, regardless of income, are entitled to, and all Americans deserve the best healthcare that our country can provide. As chairman of the Budget Committee, it is not acceptable to me that we end up spending over twice as much per capita on healthcare as other major countries around the world. Something we don't see too much on TV, you don't read in the newspapers, you don't hear it discussed here. My friends are concerned about the budget deficit, concerned about how much money we spend. Well, somebody should talk about why it is that we are spending almost twice as much per capita on healthcare as do the people of any other major country on earth, while at the same time, despite all of that expenditure, our life expectancy, how long we live, is less than most other major countries, and our healthcare outcomes in a number of areas lags behind other countries. Unbelievably, and I want the American people to hear this. You know, we talk about budget deficits or anything else here. Unbelievable, according to the Center for Medicare and Medicaid Services, CMS, we are now spending $12,530 per capita on healthcare. You got that? $12,530 for every man, woman, and child in this country. This is an outrageous and unsustainable sum of money. And here is the important point. In comparison, let's take a look at what other countries are spending for healthcare, which is as good or maybe better. United Kingdom spends $5,200. Remember, we spend over $12,000. Canada spends $5,300. France spends $5,500 per person. Germany spends $6,700. All of those countries provide universal health care, i.e. for all of their people. The key question that we should be discussing as a Congress is how does it happen that we spend so much money for health care but get so little in return? Frankly, I am tired of talking to doctors, and we'll have some here today, who tell me about the patients who have died because they were uninsured or underinsured and walked into their offices too late for untreatable conditions. And let us remember, again, not widely discussed, but we are losing, according to the best studies, over 60,000 Americans every year who die unnecessarily because they're uninsured or underinsured. I'm tired of seeing working class families and small businesses pay far more for health care than they can afford, which forces more than 500,000 Americans to declare bankruptcy each year because of medically related expenses. In America, families should not be driven into financial ruin because somebody became seriously ill in that family. Can you imagine that? Some kid comes down with leukemia and a family goes bankrupt? Does that make any sense to anybody? I'm tired of hearing from Americans who have lost loved ones because they cannot afford the unbelievably high cost of prescription drugs. And I think every senator has talked to patients, has talked to constituents who tell them what these outrageously high costs of prescription drugs have done. 1 out of 4 patients in America cannot afford the prescription drugs their doctors prescribe. You want to hear about crazy, and you want to hear about an irrational healthcare system? Crazy is when a patient walks into a doctor's office, gets a diagnosis, doctor writes out a prescription, and the patient cannot afford to fill that prescription, becomes sicker, ends up in the emergency room or the hospital at greater expense to the system. My friends, that is called crazy. I'm tired of talking with people who are struggling with mental illness but cannot afford the mental health counseling they desperately need. Last year, as you know, a record-breaking 100,000 people died of drug overdoses, and I will tell you that in my office, and I suspect the offices of every senator here, we get desperate calls from constituents who say, somebody in my family desperately needs mental health counseling. I'm worried, but far too often we cannot help them get the care that they need. It is not there because in the system geared toward the profits of the insurance companies rather than the needs of the American people, we do not have enough psychologists and counselors. We don't have enough doctors. We don't have enough nurses. We don't have enough dentists. We don't have enough medical care providers. We spend twice as much as any other major country. We don't even have the health care providers that we need to take care of our people. And also, I'm tired of seeing people in my own state and around this country who are walking around with teeth rotting in their mouths because they cannot afford the dental care that they need, because dental care is health care. And on it goes. But let's be clear about something. And this is maybe the most important point that I want to make. The current debate that we're having on health care and Medicare for all really has nothing to do with health care, because in my view, this dysfunctional healthcare system cannot be rationally defended. What this debate has everything to do with is the unquenchable greed of the healthcare industry and their desire to maintain a system which fails the average American, but which makes the industry huge profits year after year after year. While ordinary Americans struggle to pay for health care during this pandemic, and we'll talk about the impacts of the pandemic on health care, the 6 largest health insurance companies in America last year made over $60 billion in profit, led by United Health Group, which made $24 billion in the midst of the pandemic in 2021. But it's not just the profits of the insurance companies. CEOs make exorbitant compensation packages. CEOs of 178 major healthcare companies collectively made $3.2 billion in total compensation in 2020, up 31% from 2019, all in the midst of the pandemic. According to Axios, in 2020, the CEOs of Cigna, David Cordani, took home $79 million in compensation, while people died in the middle of the pandemic. In terms of the drug companies, the pharmaceutical industry, not much different. Last year, Pfizer, Johnson & Johnson, and AbbVie, 3 giant pharmaceutical companies, increased their profits by over 90% to $54 billion. The CEOs of those companies also receive huge compensation packages. So that's what the debate is about. Debate we're having is whether we have a healthcare system which provides quality care to all in a cost-effective way, whether we have a system which makes the drug companies and the insurance companies and their executives very, very wealthy. Now, in order to defeat Medicare for all, these very powerful special interests, the drug companies, the insurance companies, et cetera, have spent millions of dollars against me, against other proponents, on 30-second TV ads, full-page magazine ads, and corporate-sponsored studies to frighten the American people about Medicare for all. And I think we're going to hear some of that being discussed this morning. And this is, by the way, exactly what happened before the passage of Medicare in the 1960s, which was often attacked at that time as being socialism. Meanwhile, Medicare is today the most popular healthcare program in the country. Let me give you just a few examples of the kind of power we are up against when we try to create a healthcare system that guarantees healthcare for all people. Since 1998, the private healthcare sector has spent more than $10.6 billion. That's healthcare money that people paid. $10.6 billion on lobbying, and over the last 30 years, it has spent more than $1.7 billion on campaign contributions to get Congress to do its bidding. We pay our healthcare bills. They take that money and they spend it on lobbying and campaign contribution. Pharmaceutical industry right now, this moment, has 1,500 paid lobbyists, including the leadership, former leadership of the Democratic and Republican Party, right here on Capitol Hill, doing everything they possibly can to tell us that we should not lower the cost of prescription drugs. That's how business is done in Washington. Well, I think many of us have a different idea, and that is that maybe, just maybe, Congress should represent the American people and not lobbyists and large corporations. So, what does Medicare for All do? What is it that some of my colleagues are so strongly opposed to? Well, what this legislation do, again, would do what virtually every other major country on earth does. It would provide comprehensive health care to all without out-of-pocket expenses, and unlike the current system, would allow freedom of choice regarding health care providers. No more insurance premiums, no more deductibles, no more copayments. And comprehensive means the coverage of dental care, vision, hearing aids, prescription drugs, and home and community-based care. The transition to Medicare for All program would take place over 4 years. First year, the benefits for older people would be expanded to include dental, vision, and hearing, and the eligibility age for Medicare would be lowered to 55. All children under the age of 18 would be covered, and gradually, over a 4-year period, those programs would provide care to every American. Would a Medicare for All healthcare system be expensive? The answer is yes. But while providing comprehensive health care for all, it would be significantly less expensive than our current dysfunctional system, because it would eliminate an enormous amount of the bureaucracy, profiteering, administrative costs, and misplaced priorities inherent in our current for-profit system. Under Medicare for All, there would no longer be armies of people billing us, telling us what is covered and what is not covered, and insurance agents hounding us to pay our hospital bills. This would not only save substantial sums of money that will make life a lot easier for the American people, who would never again have to fight their way through the nightmare of insurance company bureaucracy and experience I think that almost all Americans have gone through. In fact, the Congressional Budget Office, and we're going to hear from them later this morning, has estimated that Medicare for All would save Americans $650 billion a year. So for my friends who are worried about the deficit, that ain't chump change. $650 billion a year is real money. Now, trust me, I do know this 30-second ads that will be coming from the insurance and drug companies that will tell you that if Medicare for all becomes law, your taxes will go up, and they are correct. But what they won't tell you is that on the Medicare for all, you will no longer be paying premiums, deductibles, and co-payments to private health insurance companies. And what they certainly won't be telling you is that Medicare for all will save the average American family thousands of dollars a year. Medicare for all will save the average American family thousands of dollars a year. Guaranteeing health care as a right is important to the American people, not just from a moral and financial perspective. It also happens to be what the majority of the American people want. 2020, 69% of the American people supported providing Medicare to every American. Let me conclude, and I thank my colleagues for their indulgence, and Senator Graham will have as much time as he wants. This is an issue not just of health care. This is an issue about what kind of nation we are. It's an issue whether we're going to turn our backs on 60,000 people a year who die because they cannot get the health care that they need, turn our backs on the fact that we live shorter lives than people in other countries, turn our backs and that we are spending almost twice as much per capita on health care as the people of other nations. This is an issue that has to be dealt with. Medicare for all will become the law of the land, if not now, but in the future, because this is what the American people want. And with that, let me thank Senator Graham for being here and give the mic over to him.
Thank you, Mr. Chairman. This is an important debate, important hearing, important topic, so it has tremendous budget impact, and I think it's something the nation needs to be talking about. But how does something become a law? You vote on it. So here's what I'd like to see happen. I'd like to see a vote on your proposal in this committee this year. I welcome a vote on Medicare for all in this committee this year. You have control of the Senate floor. I welcome a vote on Medicare for all on the floor of the United States Senate this year. You tell your side of the story, we'll tell ours, but if you really want this to become law, you need to start voting. So, Mr. Chairman, I'm hoping that after this speech that you will be putting your idea up for a vote. And if not, why not? Because most of your colleagues would jump out the window if they had to vote on this. After this discussion by Senator Sanders, you're wondering why we need a wall at all. The state of health care described by Senator Sanders, it certainly can be made better and needs to be reformed, absolutely. Can we spend less and get better outcomes? Absolutely. But to believe what was being said, why are so many people coming to America? Why aren't we leaving to go to someplace else where you don't die in the streets? So the facts you're describing and the activity of the American people really don't match up. If it were, as you said, one of the most disgusting examples of healthcare being provided on the planet, people would be leaving America, not coming to America. Under your proposal, every doctor and nurse, in case you're watching this, you would become a federal government employee because the only game in town would be Medicare. You'd be working for the federal government because the single provider for healthcare in this country would be Medicare, which is a government-run program. The private healthcare that you have today as an American would go away. Once you get to be 65, Medicare takes over, but below 65, people are insured in the private sector for the most part. That option goes away for you. Everybody in the healthcare system becomes a federal government employee. Everybody in America goes into a single payer system run by the federal government. Let's see where we're at with Medicare as it stands today. Medicare is an important program. I'd like to save it. I don't want to sunset it, as some people are talking about. I sure as hell don't want to invite hundreds of millions of people onto the Medicare system that haven't paid a dime, because Medicare for all really becomes Medicare for nobody over time. This is what the trustees say. Medicare Part A, which is the hospital part, will become insolvent by 2026. To rectify the $5 trillion shortfall over 75 years, you have to increase taxes by 27% or cut spending by 16%. Medicare spending expected to surge from 4% of GDP to 6.2% by 2045. We found common ground here. We need to change that narrative. We need to reform Medicare, not invite a bunch of people onto the system that would sink it. So it's in a fiscally unsound situation. I'd like to work with Democrats and Republicans to make it sound. Which would be a worthy use of our time. Now, just to remind people what life's like in America today, inflation is like beyond through the roof. 22.7% for used cars, 43.6% increase in gas prices, fruits and vegetables, dairy products, just go down the list. We're talking about the most massive increase in spending known to the United States. How would that affect inflation? Not well. So absolutely would crush an economy that needs some help. So when Americans understand what it means to do away with private health care and replace it with a one-size-fits-all, they're not so happy. Delay in getting medical tests and treatments. 70% say they would oppose a system that created greater delay. You know, Americans have become used to certain things. We like to go to the doctor of our choice. We'd like to have say about who our doctor is and get timely services. Our friends in Canada, it takes 19.8 weeks on average to see a doctor. There's 1.2 million Canadians on a waiting list of critical medical care. UK, it takes 62 days for cancer patients to start treatment. 5.8 million British residents were on a waiting list for critical medical treatment. That's their system. If you think it's hard to get to see a doctor now, Medicare for All would institute delays that I think would be unacceptable to the average American consumer. Financing for Medicare for All. All right, what would it take? One size fits all for a health care plan could cost as much as $40 trillion over the first 10 years. Taxes would double, or you'd have to cut the budget. Healthcare spending grows to 40%. GDP drops by 10% because you're crowding out the private sector. The economic consequences to this plan for the American taxpayer would be unimaginable, and it's hard enough to create a job in America now. You talk about exploding the size and cost of government. This would just absolutely crush the private sector. There are better ways. Let's save Medicare as it exists. But for people under 65, let's try to get better quality by getting the health care dollars outside of Medicare in the hands of people closer to the patient. Governors are innovative out there right now. Let's get money down to the states, give flexibility in inventing new preventive health care systems, and give consumers a choice they don't have today. Right now, Medicare is run by people you'll never meet. And we need to reform Medicare. We need to save Medicare. But the system outside of Medicare, which is a lot of money, let's get it down to the state level. Let's come up with ideas that would lower cost and increase quality. Let's create competition in the healthcare sector where innovation is rewarded, not punished. And I think that is a better way. I want to put healthcare in the hands of people that you actually will meet and have responsibility at the ballot box, so if you don't like what you're getting, you can change the results. So, Mr. Chairman, this is a debate worth having. I applaud your passion. I don't agree with your idea, but here's what I would suggest to you and others who believe in this idea. Let's vote on it. I am welcoming a debate and a vote. Now, if we don't vote on it, then it makes me wonder about it. If you think it's this great and it's wonderful and it fixes all of our problems, let's vote. Thank you.
Thank you very much, Senator Graham. We have a great panel, 5 panelists. We have Dr. Adam Gaffney, Dr. Abdul El Sayed, Ms. Bonnie Castillo, Dr. Charles Blauhaus, and Ms. Grace Marie Turner. Let us begin with Dr. Adam Gaffney. Dr. Gaffney is an assistant professor of medicine at Harvard Medical School, a pulmonary and critical care physician, and a health policy researcher. His research focuses on national healthcare reform, healthcare equity, and disparities in lung health. Dr. Gaffney, thanks very much for being with us.
Thank you, Chairman Sanders, Ranking Senator Graham, and all of the members of the Budget Committee for the opportunity to discuss this pressing issue with you today. So for the past 2 years, I have been treating patients with COVID-19 in the intensive care unit where I work as a critical care physician. Some of them, like 1 million other Americans, did not survive. But those experiences have reinforced my belief that our nation needs transformative healthcare reform, a Medicare for All program that would end much of the medical and financial suffering I have witnessed. One of my patients awakened after a long stretch on a ventilator, and their first words, I later learned, were an expression of fear about medical bills. Back then, there was at least a federal program that existed that would cover the cost of COVID-19 treatment for the uninsured. That program is now defunct. Today, Americans with COVID-19, just like Americans with cancer, with any illness or injury, can face bankruptcy because of medical bills. 1 in 5 U.S. households are carrying medical debt, which now exceeds all other forms of debt sent to collection agencies in the richest nation in the world. Medical debt should not exist, and in many other countries it basically doesn't. It is the consequence of the irrational way our country finances medical care. But the problem is not only families ruined by healthcare costs. It is worsened health due to inadequate care. Today, 30 million Americans are uninsured. These patients go without needed care day in and day out, and their health suffers because of it. In the ICU, I have cared for patients critically ill with failing hearts, failing kidneys, fluid in their lungs, because they couldn't afford routine care for common problems like high blood pressure or diabetes. And my experience is not unique. A multitude of rigorous studies have demonstrated that uninsurance is lethal. Indeed, it causes well more than 30,000 deaths every year. However, uninsurance is not our only problem, far from it, in fact. More than 40 million working-age Americans are underinsured. They're covered, but still fear unaffordable bills because of high copays, deductibles, uncovered services, and out-of-network care. And here, too, conclusive research has found dire consequences. Heart attack patients who delay going to the emergency room, risking sudden death, and children who end up hospitalized because their parents couldn't afford the copayments for their asthma medications. Sadly, I have also witnessed the consequences of underinsurance in my work. Seniors with lung disease who have rationed their expensive inhalers because of high copays, patients who've rationed their insulin and ended up with severe complications of diabetes. Typically, it is only after becoming severely ill that patients realize that their insurance is riddled with holes. Even if you have coverage, unless you're Elon Musk, you could be one illness or injury away from financial ruin. Now, Medicare for All would solve each of these problems, allowing us to cover everyone, and at the same time to improve the quality of coverage, eliminating copays, deductibles, and narrow insurance networks. It would finally give patients real choice, not the bogus choice between an Aetna or a United Health plan, but the real choice of doctor, clinic, or hospital. Now, I've indicated some of the medical benefits of Medicare for All form, but the economics are, of course, also quite relevant. This reform would uniquely produce the savings needed to cover the costs of such a major expansion of care as I've described without breaking the bank. The simple fact is that there is enormous bureaucratic waste in American healthcare, waste borne by both patients and clinicians. Of every dollar we spend on healthcare, 34 cents goes to administration and bureaucracy, twice the proportion in Canada. Much of that waste is inflicted by private health insurers. While only 2% of traditional Medicare spending goes to overhead, private health insurance companies' profits and overhead consumes 12% or more of our premiums, and much of that overhead is spent on contesting claims and denying care to patients. The bureaucratic burden of American healthcare explains the CBO's estimate that Medicare for All would achieve more than $400 billion a year in savings by reducing insurance waste alone. And in contrast, some outdated and inaccurate economic analyses have lowballed such savings, leading to spurious claims that single-payer reform would break the bank. Make no mistake, Senators, the economics matter, and as a health policy researcher, I spend a lot of time thinking about them. But what matters to me most as a physician is creating a healthcare system that will support me in delivering top quality care to all of my patients during this pandemic and thereafter. I became an ICU doctor because I wanted to care for the sickest of the sick, but I should not be seeing desperately ill patients who could have avoided the ICU altogether if they had gotten the care they needed. Those patients have been failed by a broken system that puts the prerogatives of health insurance executives over the health and welfare of ordinary Americans. Medicare for All can solve the problems of our healthcare system, covering everyone, improving the quality of coverage, expanding choice, controlling costs, and most importantly, improving our health and longevity. Thank you.
Thank you, Dr. Gaffney. Our next panelist is Ms. Bonnie Castillo. Ms. Castillo is a registered nurse and the executive director of the National Nurses United and of the California Nurses Association National Nurses Organizing Committee. NNU is the largest union and professional association of registered nurses in the United States, representing more than 175,000 nurses. And I just want to take this opportunity to thank all of the nurses in this country and the doctors as well. We have lost thousands, I think, as we all know. I heard this morning at least 5,000 nurses have died in this pandemic alone. These are the real heroes and heroines of our time, and we thank them very much. Ms. Castillo, thanks very much for being with us.
Thank you, and good morning, and thank you, Chairman Sanders, Ranking Member Graham, and members of the committee for holding this critically important hearing today. As a registered nurse and executive director of the nation's largest union of RNs, I can think of nothing more fitting to commemorate International Nurses Day today than by advocating for the urgent transition to a Medicare for All system. For more than 2 years, nurses across the country have worked on the front lines of the COVID pandemic. We have cared for patients despite atrocious working conditions that put nurses and our families at risk. If it was ever in doubt before, this pandemic has shown that our current profit-driven and fragmented healthcare system does not work. It does not provide quality therapeutic care to millions of Americans. It does not value and protect its own healthcare workers, and it is unable to provide a comprehensive pandemic response. Why didn't nurses and healthcare workers get the protections we needed in the pandemic? It was because our employers value money over our lives. Why didn't we have the emergency stocks of critical medical supplies that we needed? Because the healthcare industry makes their plans, their supply chains based on maximizing profit, not safeguarding patient care. We have seen high death rates from COVID across the country. Why? Because there are tens of millions of people in the country who are uninsured or underinsured and who therefore do not get the preventive care they need, putting them at much higher risk for severe COVID illness, hospitalization, and death. But the problems with our healthcare system far predate this pandemic. For years, nurses have witnessed the tragedies that result from a profit-driven healthcare system. Nurses watch so many patients forego needed care because they can't afford the cost. They watch as insurance companies deny life-saving care, overriding the professional judgment of nurses and other medical professionals. Nurses watch as patients come to the emergency room with advanced stages of illness or disease that could have been avoided if they had had access to preventive care. The system we have now is beholden to the corporate interests that determine who gets treatment and when they get it. The United States spends more money per capita on healthcare than any other nation in the world, and yet we have the worst health outcomes when compared to other wealthy countries. This system is unaffordable for our country and for our patients, and the pandemic has shown that our society cannot afford the public health consequences. The only way to solve the healthcare crisis is to enact a single-payer Medicare for all system. Under Medicare for all, every person living in the United States would get a quality therapeutic healthcare regardless of the ability to pay. We would transform the profit-driven health insurance system into one that actually prioritizes patient care. As a registered nurse, I can envision exactly what Medicare for all would mean for patients. Whenever someone needs medical care, they would see the healthcare provider of their choice without any worry about financial barriers to care. We would no longer see patients suffer because they can't afford care. Patients would no longer have to actually ration their medications. For healthcare workers, we would be able to provide medical and nursing care based on our professional judgment without the interference of insurance companies. The Medicare for All Act would allow for tangible, practical improvements to the healthcare delivery, and importantly, it would change the way that hospitals are paid, fundamentally shifting their profit motives so that they prioritize patient care and worker health and safety instead. By paying hospitals through global budgets, the bill would ensure that hospitals have the funding necessary for safe nurse-to-patient staffing ratios, pandemic preparedness, and occupational safety and health programs. The programs would ensure that hospitals in rural and underserved areas always get the funding they need to stay open. And it's designed to address healthcare inequities at their core by changing the systems that limit healthcare for low-income communities and particularly for communities of color. As registered nurses, our primary responsibility is to protect the health and well-being of our patients. Our existing healthcare system does not allow us to do that. Medicare for all is the solution we need to ensure that every patient gets the healthcare they need. Thank you.
Ms. Castillo, thank you very much. Our next panelist is Dr. Abdul El Sayed, who is a physician, epidemiologist, and educator. He is a Townsley Foundation policymaker in residence at the University of Michigan Gerald Ford School of Public Policy. Formerly, he was health director for the city of Detroit, where he was responsible for the public health needs of over 670,000 people in that city. Dr. El Sayed, thank you very much for being with us.
Thank you, Chairman Sanders. Got it. Chairman Sanders, Ranking Member Graham, and members of the committee, thank you for the opportunity to testify before you today. My name is Dr. Abdul El Sayed. I trained as a physician and epidemiologist and served the city of Detroit as health director, where one of my responsibilities was rebuilding a health department that had been shut down during the Great Recession. Today, I teach at the University of Michigan's Ford School of Public Policy. There, I find myself explaining the haphazard dysfunction of our current healthcare system to some of the brightest young minds in the country. What's a deductible? Well, it's like having to pay an extra $19.99 to watch a movie on Netflix that you thought you already paid for. Only this time, it's for your basic healthcare needs and it's thousands of dollars. They remind me how much nonsense we accept as normal in our healthcare. It's partly why I recently wrote a book on the very subject, Medicare for All, A Citizen's Guide with Dr. Micah Johnson, and I furnished a copy to each one of your offices. I want to start with the two most obvious problems in American healthcare: incomplete coverage and spiraling costs. To understand them, I want to correct a basic misunderstanding of how we approach healthcare in this country. We like to think of ourselves as consumers, as customers, but we're not. Let me just share how being a customer works, just to review. Let's say you want some tomatoes. You go to your local farmer's market, you find a stall with some you like, you ask the seller for the price, and if that price is too high, you walk away. But if it's good, it's fair, you buy, you tender your payment, you get your tomatoes. That is a normal customer experience. But healthcare is not that. If I were to have a heart attack right now, in this room, I'd be rushed to the nearest hospital with no choice of what hospital I go to. I'd have no choice of what doctor I see, what treatment I get. No one shows me a price list, and I have no opportunity to just walk away if I don't like anything. I'm having a heart attack after all. Afterwards, a bill is not sent to me. It's sent to a third party, my insurer. And rather than being the initiator and completer of a financial transaction, I'm the reason a financial transaction happens between my insurer and my provider. So ask yourself, given the usual customer experience, are we as American healthcare consumers, are we the customers or are we the tomatoes? Healthcare is simply just not a market product. The health insurance industry assures that. You might expect insurance companies to want to negotiate healthcare costs downward. After all, they are the payer, but they don't. It's one of the unintended consequences of the so-called 80-20 rule, requiring health insurance companies to spend at least 80% of what they collect on premiums in healthcare. After all, ask yourself, what's the best way to grow your 20% piece of the pie? Make sure you got a bigger pie. So they make the pie bigger and they pass those costs back on to us in the form of premiums and deductibles. Premiums have risen faster than inflation and wages over the past decade, and deductibles have more than doubled, and those are dangerous. One study found that high deductibles was associated with a 9-month delay in getting treatment for breast cancer. The operative part of the word insurance is supposed to be sure, but in our for-profit system, you can't really be sure of anything. And those are the first-class healthcare citizens. There are, of course, the second-class healthcare citizens. Over 100 million of them, 28 million who are uninsured, 87 million who are on Medicaid, a critical but underfunded lifeline program. Medicaid reimburses far lower than private health insurance, so a lot of providers just don't accept it. Now, here's the thing. Reimbursing the same exact healthcare services at lower rates reflects an implicit lack of value of the body for which that healthcare is being provided. You cannot deny it. And those bodies in this country are disproportionately black and brown, disproportionately rural. Meanwhile, the prices keep rising. Corporations keep making money when they do. And we spend more than $12,000 per capita per year on healthcare, more than twice as much as our counterparts in Canada. They live 4 years longer on average, by the way. In the pandemic, it demonstrated that coverage and costs aren't our only issues. Early on, healthcare workers struggled without ventilators or beds or basic PPE. 27 million Americans lost their employer-sponsored health insurance with their jobs. Local and state health departments and the CDC struggled under the weight because they were already anemic from the disinvestment during the Great Recession. So despite the need for more beds, 21 hospitals shut down in 2020 alone. That's including 73 over the past decade, 4 in Senator Graham's South Carolina alone. But guess what industry had a banner year in 2020? The health insurance industry. They got to keep all of the money that didn't get spent on elective procedures, which, by the way, are why those hospitals shut down. American life expectancy dropped 25 years, dropped by 3 years, wiping out 25 years of growth. So what did we learn? Even with private insurance coverage, it's not durable. It's liable to be lost to you, precarious, as we saw in the pandemic. American consumers are losing their healthcare choices through hospital closures and mergers and acquisitions, which, by the way, allow large healthcare systems to exploit workers, including nurses and doctors. And we're failing to invest in public health. Now, the genius of Medicare for All isn't just that it solves coverage and cost. It's that a universal national health insurance program for everyone offers a solution for each of these problems. Medicare for All is the clearest pathway to universal, durable healthcare insurance, bar none. Cradle to grave coverage would do away with the premiums, copays, deductibles that leave even privately insured Americans rationing their healthcare today, just like they do every day in America. Medicare for All would expand healthcare choices by limiting hospital mergers, acquisitions, and shutdowns that threaten those choices, and empower mammoth healthcare systems in the process. It would also empower healthcare workers. And it finally addresses the misincentives that we have to invest in prevention and public health. So to conclude, opponents of Medicare for All are going to tell us all of the same fear-mongering arguments we've actually already heard today. They're going to say that Medicare for All would eliminate healthcare choices, but really it is critical to preserving the choices Americans actually care about, which are the choice of doctor, the choice of clinic, the choice of hospital. They'll say we can't afford it when American families cannot afford the system that we have today. What about innovation, they'll ask? Well, providers stay private under Medicare for All. Never mind the fact that our federal government is the most important funder of biomedical research in the world. But rationing, what about rationing, they'll say? Well, out-of-pocket costs are forcing Americans to ration healthcare every day in the current system. They'll tell us that Medicare for All is somehow un-American. But what really is un-American is staring at our broken healthcare system in the face while it's breaking people in the process and choosing to look away. Today, you're choosing to stare it in its cruel, indifferent face. And I commend you for doing this. And I hope that I've offered some insights into how and why it's broken and how Medicare for All is the solution to fix it. Thank you.
Thank you, Dr. El-Sayed. Our next panelist is Ms. Grace Marie Turner, who is president of the Galen Institute, a public policy research organization that she founded in 1995 to promote an informed debate over free market ideas for health reform. Ms. Turner is founder and facilitator of the Health Policy Consensus Group, which serves as a forum for analysts for market-oriented think tanks around the country. Ms. Turner, thanks very much for being with us.
Thank you, Chairman Sanders, Ranking Member Graham, Senators, for the opportunity to testify today. Mr. Chairman, I'd like to begin by acknowledging my respect for your tireless work on universal coverage. While there are different views about how to reach that goal, I believe there really are important values that we share in achieving universal coverage, care that's affordable, protecting quality and choice, and especially a strong safety net for the vulnerable. Americans are frustrated with our current health sector, with millions still uninsured. Those with insurance find their coverage costs too much, and deductibles can be so high many people feel they aren't even insured. But the more government gets involved, the more providers must comply with the legislative and regulatory demands instead of innovating to respond to the needs of patients, families, and employers. Wharton Professor Mark Pauly finds that the federal government exerts a great influence over our health sector today, with government-controlled or directed spending totaling 80%. In proposing policy solutions, I believe it's important to begin by clearly defining the problem. The overwhelming majority of Americans today have access to coverage. More than 30 million people are uninsured, but 2/3 of them are eligible for programs that they aren't enrolled in, either in the private or the public sector. Among the remaining 1/3, most of them are here, they're undocumented immigrants, which is more of an immigration problem than it is a healthcare problem. Uninsured rates continue to be higher among Latinos and Blacks, people with incomes below the poverty level, and people in states that have not expanded Medicaid. We could work together to make sure these 30 million people that are eligible for coverage have access to care and coverage. Medicare for all would mean that virtually everyone would lose the plans they have today in exchange for this one government-run health plan, including 173 million Americans who have coverage through the employer that they value, and the 64 million Americans, seniors who on Medicare, seniors who've paid into the Medicare program throughout their working lives to have medical coverage when they retire. Several states have tried to implement a single-payer plan, including the chairman's home state of Vermont. Colorado took a vote on the single-payer, and California most recently shelved their single-payer plans. They learned the proposal would have required the largest tax increase in the state's history of more than $12,000 per household annually to meet the $400 billion plus annual cost. And according to the Kaiser Family Foundation, as the chairman said, 2/3 of Americans say they support a plan that would guarantee health coverage for all. But also, as the ranking member said, that figure drops to 37% when people learn it will raise taxes and eliminate their private health insurance. It drops to 26% when people learn they can expect delays in receiving treatment. As several of our witnesses have said, delayed or denied care can, in fact, cost lives. Sally Pipes, who runs the Pacific Research Institute and was born and raised in Canada, said her otherwise healthy godson went to a Vancouver emergency room earlier this year with chest pains. Doctors gave him an electrocardiogram and a chest x-ray, but not a CT scan. CT scans are notoriously difficult to get in Canada because of the scarcity of equipment. They sent him home with some pills. The next morning, he was found dead in his condominium. The autopsy showed a torn aorta, which the CT scan would likely have detected and which likely could have been repaired. Evidence abroad shows that Medicare for All would lead to restricted access to new medicines, diagnostics, and treatments, fewer innovations in personalized care, lower payment rates that would force physicians and other providers to curtail services or even close their doors. We saw this happen just up the street at Providence Hospital that became too reliant on Medicaid funds and after a century and a half had to close its doors to acute hospital treatment. I would like to commend Ranking Member Graham for his hard work on proposals to usher in a new era of health reform by unleashing the innovation and energy pent up in our health sector to solve so many of the problems we're facing. Senator Graham has provided ideas and guidance for the work of policy experts from 82 organizations that have signed on to the Healthcare Choices Plan, as dozens of recommendations to encourage choice and competition, offering more options for more affordable coverage, more choices, and better care for those who have the greatest health needs. Thank you for the opportunity to testify. I look forward to your questions.
Ms. Turner, thank you very much. We have one more panelist, Dr. Blauhaus, but before we get to him, I'd ask unanimous consent that Senator Merkley be allowed to speak as he has to run to another appointment. Senator Merkley?
Thank you very much, Mr. Chairman, and I appreciate this conversation so much because our healthcare system is so enormously stressful. There are so many cracks, so many different forms of medical care, and people are always falling between them. Just this last weekend, my son was in the emergency room with COVID. He had just turned 26. He's applying for COBRA, but it takes weeks to get that number. And so the first thing he was asked is, where's your insurance card? And he handed over his insurance card, and he was told, well, we're sorry, this just expired because it's past your birthday. And just constantly, people are stressed out by the complexity and the cost of our system. I thought I'd try to quickly address a few of the points that my colleague from South Carolina has made, because I see it a little differently. He mentioned the southern border, and we do see a lot of people on the southern border coming from very poor countries where there's a lot of issues, and they're seeking a better life. But really, the comparison we're talking about is between other developed countries and the United States. So I'd ask unanimous consent to submit this chart for the record, and I'll hold it up for the camera. This is the rest of the developed world up here. Much better health care, much lower cost. Here's the United States down here in the corner. Much higher costs, much lower quality. Well, that's why we're having this conversation. The rest of the developed world has figured out that you can provide much better health care at much lower cost. And that's what Medicare for All is all about. Second, my colleague made the point that everyone would work for the federal government. But this is not a single provider proposal. This is a single payer proposal. That is completely different. Single payer proposal, like Medicare, the providers are the providers we have today. And then my colleague mentioned inflation. But what is worse for America than the inflation we have in the medical system? It's massive because there isn't competitive forces to drive it down. And my colleague mentioned that competition we should introduce into the system, but as pointed out by our witness, it doesn't really work in the medical world. And if you want competition, you want everything to be in network because that way everyone's competing. Well, how do you get in network? You take Medicare for All. And if you really want competition with the existing system, you didn't support Medicare for All, then you support a public option. We have a public option in my home state of Oregon for insurance in the workplace. It's called the State Accident Insurance Fund. Private business chooses the public option over the private option more than half the time. And that competition actually drove down the cost a lot. But therefore, that is, if you want competition, you don't want the current existing system. And then our witnesses talked about the inefficiency. I think about all the providers who say they spend all their time sorting through the many different insurance systems trying to figure out what they can charge. That's a huge waste in our system. I think about all the businesses that say we spend so much time wrestling with which new insurance plan to try to keep the cost down while still offering insurance through our company. That's a huge waste of time and effort. And then we heard about medical debt, and we heard about underinsurance, and we heard about medical rationing. We have innumerable problems in this current system that Medicare for All will address. And in my 1 minute remaining, I'd like to ask a question to our expert on nursing, Bonnie Castillo. My wife is a nurse, so I take special interest in this. How will the provision of nursing workforce or nursing quality be affected by going to a Medicare for All system?
Thank you. And, obviously, we have been dealing with an industry-created nurse staffing crisis for many years. Right now, we have 1.2 million nurses with active licenses that are not working. And, they're not working because many have left because of the poor working conditions, and more have left in the last 2 years in particular, which is because of everything that they're seeing in terms of the denial of care, and the fact that they, as I said before, the atrocious conditions in the hospital. And if the nurses are not able to give good quality care that they are expertly trained to give, that creates great moral distress. And to see so many patients suffering because they're suffering from illnesses that with a little bit of prevention and early care could have prevented a more acute situation for them, that has been very, very difficult. So providing Medicare for all, getting early care, preventive care, that allows us to do what we do as nurses, and that is to provide good, comprehensive care.
Thank you, and just a huge thank you to all the nurses who make the world better, one bedside at a time.
And if I could add, too, for the record, that really Congress needs to pass mandatory minimum safe nurse-to-patient ratios, and they can do that independently now.
Okay, Senator Merkley, thank you. Now we're going to get back to regular order, and that is our last panelist is Dr. Charles Blauhaus, who's with us virtually. He is the J. Fish and Lillian F. Smith Chair and Senior Research Strategist at the Bricatus Center at George Mason University. Dr. Blauhaus specializes in domestic economic policy and retirement security with an emphasis on Social Security as well as federal fiscal policy. Dr. Blauhaus, thanks very much for being with us.
Well, thank you, Chairman Sanders. Thank you, Ranking Member Graham, members of the committee. I greatly appreciate this opportunity to discuss the federal budget costs of Medicare for All. Before I summarize my findings, just a brief caveat. My testimony is largely based on analysis that I performed in 2018. Current proposals differ in key respects from the provisions that I studied. So at the end of my statement, I'll discuss how recent developments might change these numbers. Now, my study found that Medicare for All would add somewhere between $32.6 trillion and $38.8 trillion in new federal budget costs over the first 10 years. The $32.6 trillion scenario essentially assumed that every cost containment provision in the bill saved as much as possible. If instead things played out more consistently with historical trends, the added cost would be closer to $38.8 trillion. The study also noted that doubling all currently projected federal individual and corporate income taxes would be insufficient to finance even the lower bound estimate of $32.6 trillion. Now, the vast majority of these costs arise from the federal government's assuming responsibility for health spending that is now done by others, by state and local governments, by private insurance, and by individuals out of pocket. And certain aspects of Medicare for All would add to this health spending, while others would seek to bring costs down. The biggest factor Increasing health spending would be Medicare for All's expansion and increased generosity of health insurance coverage. Spending on behalf of the currently uninsured would rise, as one would expect and presumably intend. Additional benefits would be provided that Medicare currently doesn't, such as dental, vision, and hearing services. But most importantly, Medicare for All would provide first dollar coverage of Americans' health expenses, meaning, with only a few exceptions, no patient cost sharing. Now, this would increase the demand for health services because the more of people's health care that is financed by their insurance, the more they tend to consume. So under Medicare for All, the federal government would assume responsibility for financing healthcare services above and beyond current demand. Now, other provisions of Medicare for All are intended to reduce costs. My study assumed substantial administrative cost savings and bracketed a range of possible outcomes of provisions intended to lower drug prices. The big variable here is payment rates for healthcare providers. Current bills envision that payments would be set through processes similar to Medicare's, and Medicare pays providers much less than private insurance does. If Medicare for All paid providers at Medicare rates, payments for services now covered by private insurance would be sharply cut by more than 40% for inpatient hospital care, more than 30% for doctor services, and so forth. Now, such payment rates would be substantially below providers' reported costs of providing services. So for this and other reasons, several studies assume Medicare for All must adopt higher payment rates than current Medicare does. And this, of course, leads to higher federal cost estimates and findings that Medicare for All would further increase national health spending. Now, since my study was published, more recent proposals have generally included additional benefits I didn't estimate, such as long-term services and supports, and that pushes costs up. But other developments would lower the projected cost. Baseline projections for national health expenditures have gone down a little bit. Also, the so-called Cadillac plan tax was repealed, and other health-related taxes have been repealed, and this increases net federal health subsidies under current law and thus reduces the additional costs posed by Medicare for All. CBO has also found that many services would continue to be financed outside of a Medicare for All system. When you account for this, that further lowers the federal cost estimate, though of course it doesn't lower national health spending. Perhaps most importantly, CBO found that much of the new demand for healthcare under Medicare for All would simply go unmet. Now, this also lowers projected costs, but obviously it's bad news for patients who would be denied care. It's reasonable to guess that a re-estimate of my realistic payment scenario might drop its 10-year cost from roughly $39 trillion to about $31 trillion. Now, this would still be more than we could finance by doubling all projected income taxes, and it would still mean a net increase in national health costs. One last important point. CBO projects lower administrative costs than mine and most other studies do. And for example, they project that 80% of nurses' current administrative tasks would be eliminated by Medicare for All, and that all the time saved would be reallocated to providing care. Now, the implications of these assumptions are very significant. If we were a little bit less optimistic about the administrative time saved, we'd see a much bigger problem with denial of care. For example, if Medicare for All reduced nurses' administrative tasks by 40%, which is still quite optimistic, then if we paid providers at Medicare rates, nearly all of the new demand for hospital and physician services under Medicare for All, 97% of it, would go unmet. Now, lawmakers would be very unlikely to tolerate that outcome and would probably address it by paying providers more. So that's an additional reason why the actual costs of Medicare for All would probably be much higher than in these various studies' lower cost projection scenarios. I hope this information is useful. I thank the committee again for the opportunity to discuss these important implications of Medicare for All.
Dr. Blahouse, thanks very much for your testimony. Okay, I think we begin the questions right now. Let me start off with one very simple question and kind of a yes and no answer, maybe for all of our panelists. Is healthcare a human right to which all Americans are entitled, regardless of their income? Dr. Gaffney?
It absolutely should be.
Okay. Ms. Castillo?
Yes.
Dr. El-Sayed?
Yes, sir.
Ms. Turner?
Yes, sir, but we also, the people who are providing that care have an equal right for compensation.
Dr. Blahouse?
I believe everyone is entitled to receive care. It is a necessity.
Okay, thank you. Let me start off with a question for Dr. Gaffney. During the pandemic, we saw the absurdity of tying healthcare to employer-based coverage. Some 27 million people lost their jobs, and when they lost their jobs, they lost their health care. In your view, should health care be something that all people are entitled to because they are human beings, or should it be, in most cases, attached to their employment? And when it's attached to their employment, it may well be, I have a good job and I have great health care coverage. He doesn't have a good job, his coverage is minimal. Is that system making sense to you as a physician?
Well, it doesn't make sense either medically or financially. For one thing, you constantly hear the critique of Medicare for All that it would take away people's private health insurance. As you said, people are losing private health insurance all the time because they got fired, they got laid off, they turned 65 and gained access to Medicare. So it doesn't make sense. Furthermore, that sort of churn, as we call it, the constant shifting in and out of medical plans, healthcare plans, has really adverse consequences for patient care. You could imagine if you have complex medical needs, having to see a number of doctors, having to go to particular hospitals. All of a sudden, your healthcare plan changed. Now you need to see all new professionals. Assuming you still have a new plan, you may be entirely uninsured and unable to see anyone at all. So it doesn't make sense, no.
All right, let me go to Ms. Castillo. If we had already adopted Medicare for All before the pandemic, how would things have been different for frontline nurses and their patients? Would our hospitals have been better prepared to protect patients and employees?
You know, and actually this just to relate to the previous questions, imagine, all those folks that lost their jobs in the midst of a deadly pandemic. So if we had Medicare for All before this pandemic started, hospitals would have been better prepared to respond. There would have been a system in place. For years, hospital corporations have used and relied on this just-in-time staffing and for supplies. And in most of the countries, hospitals didn't even hire enough nurses for regular patient care day to day, and that's pre-pandemic. They didn't have enough supplies for a public health emergency. Through the global budgeting payment mechanism that's in your bill, Senator, hospitals would be required to have the minimum minimum nurse staffing levels, and they would be required to have a 1-year supply of the critical PPE and all the other medical supplies that were needed. So our pandemic response would have been much safer for patients and for healthcare workers if we had a Medicare for All system.
Thank you. Dr. El-Sayed, my conservative friends are supposed to worry about how much money we spend, right? That's what being a conservative is about. And I share some of that, I like to spend money.
One of the things, yes.
I was kind of a cheapskate mayor and try to continue to do that. So I just don't understand why my Republican friends are not jumping up and down and saying, Bernie, we're with you. It's a little bit crazy that we're spending twice as much per capita on healthcare as the people of other nations. And we can argue, we all hear the scare tactics from Canada or UK and so forth and so on. But I would remind my Republican friends that conservative governments have been in power in Canada, in the UK, you're in the UK right now, and they would not for a second try to get rid of their national healthcare system because it is so popular. But my question to Dr. El-Sayed is, tell us, why is it, in fact, that we are spending over $12,000 a year on healthcare, twice as much as our Canadian friends, the French, British, countries all over the world, while we live shorter lives, and in many cases, our healthcare outcomes are not as good? How does that happen?
Well, we talked a little bit about the tomato scenario and the fact that, in our system, nobody has an incentive to save money. If you're a provider, your incentive is to bill more because you make more. And if you're an insurer, your incentive is to grow your piece of the pie, that 20% that you get to keep, so you have no incentive to keep it down either. And they keep pushing the bill back onto the rest of us. But because we have so many payers and so many providers, 700 health insurers in our society.
How many health insurance companies?
Right around 700.
Okay.
There is no one of them has the power to actually rein down the prices, even if they wanted to. And on top of that, you have to have a whole bunch of crosstalk, a whole bunch of billers, whether it's on the provider side or the payer side, to be able to make these financial transactions happen. That's overhead in the system
Let
that
me
all of
ask
us
you
pay
this.
for.
Does anybody have any idea? We've talked about not having enough doctors and nurses, et cetera. How many people do we have in the system who do nothing else but bill us and drive us crazy that we're late on our bills? Anyone know the number of that?
I don't know if Adam has an
Adam,
estimate.
do you know, Dr. Gaffney?
I don't have the personnel number, but I do have the overall expenditures of what we spend on administration, and that's 1/3 of every healthcare dollar in the United States to administration, double the proportion of Canada.
So we are spending hundreds of billions of dollars on folks who bill us and drive us crazy, but do not provide any health care to us.
That's right.
Dr. El-Sayed?
And so that's one piece of the deep inefficiency in our system. The other piece is that we just don't invest in the means of prevention almost at all. I told you, one of my jobs was to rebuild a health department in America's poorest city. We have fundamentally disinvested in the means of keeping people healthy over the long term, the kinds of things that save money over the long term, in large part because nobody has an incentive to do that. Our system is predicated on a financial transaction after someone gets sick. So if you think about the political economy of it, there's very little incentive to prevent at all.
In terms of cost savings, and I say this to my conservative friends because I know that they're worried about expenditures, if we lowered the cost of prescription drugs in this country to what other countries pay, anyone have any idea how much savings there would be in our system? Dr. Gaffney?
I mean, the CBO estimate was about a 30% reduction in drug prices. Other countries pay probably on average about half as much. You're talking about more than $100 billion. Yeah.
Okay, that's Senator Graham.
One, I thoroughly enjoy the committee. Good. I really do. Now, to can I call my liberal friend, socialist friend, what would you like to be called?
What's called friends?
Okay, a friend. You can call me conservative and I won't object. So, to my friend from Vermont, you're right. We can lower costs and improve quality. The question is how. Do you agree with that, Ms. Turner?
Absolutely.
Okay, how do you get innovation in a system? Dr. El-Sayed, outside, is that right? I'm sorry.
El-Sayed.
Yeah, well, count me in for innovation, count me in for lowering costs, count me in for improving quality, and makes all the sense in the world. But let's talk about tomatoes. Who grows tomatoes in America? Anybody expert on tomatoes? The government doesn't grow tomatoes. Tomatoes are grown by the private sector, and there's competition in the marketplace to grow tomatoes. And we don't do collective farming. And the last thing you want in the tomato world is to have the government take over the production of tomatoes and go to the Soviet-style collective farming where everybody eventually starves. So let's keep tomatoes the way they are and let's improve healthcare. So the bottom line is I'm looking for a system that would lower cost, improve quality, and I'm begging you to have a vote on your bill. I am begging you, I'm encouraging you, I'm asking President Biden, in case you're watching, please call Senator Schumer and insist that we have a vote on Medicare for all on the floor of the United States Senate as soon as possible. And we won't, because Democratic colleagues know that it would go over like a lead balloon with the American public. Maybe I'm wrong. Maybe you'd win the day, but we're not going to fix this problem until we start voting on solutions and alternatives. Dr. Blahaus, is that right?
Yes.
If every hospital in America went to Medicare reimbursement rates for their primary source, their only source of payment, how many hospitals would close?
Well, it's hard to say how many would close. The CMS Medicare actuaries have said that the vast majority of hospitals operate at a negative margin for their Medicare patients, their Medicare treatments.
So they make it up through the private pay system, is that correct?
That's correct. And they put out a projection a couple of years ago saying that, roughly 80% of facilities would be plunged into negative margins within a few years if all of their reimbursements were at Medicare rates.
Ms. Turner, what's your view of that? What if America, all of a sudden, everybody in the hospital arena were reimbursed at Medicare payments at the current rate, and that was it?
Well, this is a good question to ask for this director of the Congressional Budget Office, because they have basically said that a great majority of physician practices and hospitals and clinics would simply not be able to keep their doors open. The private sector, employer-based health insurance in particular,
If you spent 15
supplements
minutes
that.
talking to the people in South Carolina, in rural areas, their biggest nightmare is to be locked in at Medicare and Medicaid rates, because they'd have to close, because you just can't pay the cost. And if you start mandating patient to nurse ratios, that increase your cost. So a lot of hospitals will go out of business. There's got to be a better way. So the idea of having the government as the only source of revenue is, I think, a bad idea, because you're no better than the government will allow you to be. And you would have to increase Medicare and Medicaid reimbursement rates, or you would shut down a large number of hospitals in this country, because they literally can't operate without a private pay function. Let me ask this question. Do you all agree that under Medicare for All, private health insurance options go away for the American people? Everybody's nodding. Okay, I just want to get that baseline. The question is that a good idea or a bad idea? So what I would like to do, Mr. Chairman, is vote on your proposal. That is, I like the committee. We talk a lot. We don't vote on much of anything. Let's take your idea and vote on it, because if we did that, I think you would find out that Medicare for All would be the equivalent of collective farming over time. And I don't want to go down that road. I'd like to do more private sector involvement in healthcare, not less. I'd like to have more competition, not less. I'd like to get more innovation, not less. And I can tell you one thing, the more you consolidate power in the healthcare arena under the government umbrella, you're going to get less of innovation, you're going to get more in cost, and you're going to get less in quality. You just have to wait longer. You have to ration care, because eventually you break the budget to the point it can't be repaired. Medicare is in a very tenuous situation. Let's focus on saving Medicare as we have it today, and let's find ways to talk with each other about lowering that cost from $12,000 per patient to something lower, and see if you can have an open mind to some of my ideas, and maybe I'll have an open mind to some of your ideas. Might be able to fix this thing over time. But let's start with this idea. We should be voting on this. We shouldn't be talking about it any longer. Let's vote.
Well, if I could just briefly respond before I give the mic to Senator Padilla about voting.
Can I say one thing I forgot? Unanimous consent to submit letters and op-ed to the record for Freedom Works, Council for Citizens Against Government Waste, American for Prosperity, Americans for Tax Reform, and the Cato Institute, as well as an article from the Washington Post.
Without objection.
Thank you, Mr. Chairman.
Senator Graham, you may or may not know that I have been one of the major proponents in the Senate to have more votes. I like votes. I think it brings forth debate. But I think while we're at it,
You're the
in
chairman.
addition, I'm the chairman of this committee, but not the majority leader. I think we should vote on whether we continue massive tax breaks for billionaires so that Jeff Bezos in a given year doesn't pay a nickel in taxes. I think we should vote on whether we end Citizens United so that billionaires are not able to buy elections as they're doing it right now as we speak. I think we should vote on whether or not Medicare should negotiate prescription drug prices so that we can lower the cost of prescription drugs in this country in half, and a lot of other issues. So you're talking to the wrong guy here. I like the idea of votes.
Well, with all due respect, Mr. Chairman, you're the chairman of the committee. This is about Medicare for All. If you want to vote on all those things, fine. Let's start with your idea.
Let's vote on all of them. Good.
Well, let's start with Medicare for All. Have a vote next week.
All right. Okay, Senator Padilla.
Thank you, Mr. Chairman. And I want to start by thanking you for your leadership on this issue and for holding this hearing. I am proud to support Medicare for All and look forward to working with you to move this forward. And I also want to personally thank and recognize our frontline heroes. I see all these scrubs in the audience, and always puts a smile on my face because I know that y'all have been on the front lines in the more than 2-year fight against COVID-19. Also want to say that pandemic. We have a few heroes today and some great witnesses, including one that happens to be a California nurse and my personal friend, Bonnie Castillo. Thank you for being here. Now, Ms. Castillo is Executive Director of the National Nurses United and a fierce advocate for equal health care for all. And I'm proud that she's here representing California as well as the workforce. Now, as we've all seen, the COVID-19 pandemic has put a spotlight on what many people of color already knew. And that's the fact that the current healthcare system does not treat everyone equally. For far too long, communities of color, patients of color, have faced discrimination in our healthcare system. And we can debate whether it's intentional or unintentional, but the facts and the data are clear. And that's one of the reasons why I believe Medicare for All is so important, because it will level the playing field for communities of color. It's simply a fact that many communities of color living in the United States have less access to health care, have worse health outcomes, and are less insured than other communities. But a significant equalizer has been Medicare. Research has shown that there are substantial reductions in racial disparities in access to care and self-reported health when people reach 65. Now, this is striking and should be kept top of mind when we consider this bill. Healthcare should not be determined by your zip code, and no one should go bankrupt because they can't afford growing medical expenses. So I share your conviction, Mr. Chairman. It's frankly unacceptable that as the wealthiest nation in the world, we don't guarantee health care for all. Health care is a human right. I'm looking forward to taking action here. Now, turning to my questions in a couple minutes that I have left. The first is to Ms. Castillo. Cost is often cited as a reason to oppose Medicare for all, for those who don't believe yet. But the real question I have is cost for whom? Now, I've heard story after story from families across California about how a single illness can be financially crippling for an individual or a family. Families often go into massive debt or even bankruptcy to cover a loved one's healthcare costs. But it doesn't have to be this way. Healthcare should not be something only the wealthy can afford. No one should go into debt because of rising healthcare costs or an illness. One example that we're legislating separately, no one should have to ration their insulin or put off critical surgeries because of the price tag. So with that as the backdrop, Ms. Castillo is one of the leaders of the largest healthcare worker unions in the nation. How would Medicare for All help alleviate the racial and income disparities that you see on the ground?
Well, thank you, and thank you for your leadership, Senator Padilla. For us as registered nurses, I think, the key words is early access, prevention, detection, and treatment. And that means removing those barriers. And those barriers are prohibitive, whether you have, for the uninsured, as has been mentioned, for the 30 million uninsured, but for the underinsured that can't afford to use their insurance, not to mention all those who have lost their jobs and lost their insurance. Insurance doesn't equal care, and people need to be able to access that care and the care that, and we on this panel, we have the expertise and the education to provide that care. That's what that is our job. And we do our job every day. We do our job. And during the pandemic, we didn't run away from the disaster. We ran to it. But we need the tools, and we need to remove the barriers to care for everyone. And the COVID does not respect any kind of barrier to care. It is going to, if it infects one of us, it can infect all of us. And so as providers, we need to, it's important that we address these. I will also I'd like to comment on, for instance, hospitals are closing all the time. We, as a union, fight hospital closures and they're deciding to close because it's simply not profitable to operate a hospital in the lower income communities, specifically communities of color, rural communities. And so if we had the global budgeting where the budgeting was based on need, human need, then we would be able to work to decrease those disparities that exist.
Thank you. And Mr. Chair, I know my 5 minutes are up, but if I can, just one quick question. I promise to be brief. The COVID-19 pandemic has also put enormous stress on the mental health of the American people. Cases of mental illness and substance abuse disorder have sharply risen during the pandemic, and more people are seeking care. Often cost and stigma pose barriers for people seeking mental health treatment. That just shouldn't be the case. Medicare for All, I believe, can also help level the playing field for those suffering from mental illness, not just physical illness. Dr. El Sayed, how can Medicare for All help those suffering from mental illness and substance abuse disorder?
Yeah, Senator Padilla, I really appreciate the question. We are suffering a second pandemic of mental illness in this country, and unfortunately, our healthcare system has done this thing where we basically decapitate the head from the body. We say if it's in the head, whether it's mental health or it's dental health or it's vision or hearing, then we're going to pay for it separately. And one of the best pieces of Medicare for All and the chairman's bill is that it reminds us that making Medicare whole is really the first step to extending Medicare for everybody. Covering these critical needs is critically important. The second point here is that because we have such a different system of reimbursement for mental health, we systematically lag in terms of capacity. My own spouse is a mental health provider, she's a psychiatrist, and every day she talks about caring for students who would not have care, except for that they happen to be students at the university and get it through their university. And so putting the head back on the body of healthcare and making healthcare whole through Medicare for All, ending the differentiation between the head and the body, I think is critical, and Medicare for All would do just that.
Thank you. Thank you, Mr. Chairman.
Senator Johnson and Senator Padilla, would you mind sharing while I run down and vote? Senator Johnson.
Thank you, Mr. Chairman. You're going to miss some good stuff here. The first step in solving any problem is admitting you have one. We all admit we have one, right? But then you have to properly diagnose it. And I think that's where things break down pretty quick. Seems like the chairman says it's all about profitability in the industry. He rattled off a bunch of numbers, totaled up $117 billion. Dr. Gaffney, you talked about lowering drug costs, $100 billion. We spend over $4,000 billion a year in healthcare. Even if you get after-tax profitability of 10%, which I think is probably high, if you take a look at the entire industry, that'd be about $400 billion, and you'd still end up with over $11,000 per person. So the profits, yeah, if you squeeze out all profitability, you could lower healthcare costs, but not that substantially. What astounds me is the people that promote Medicare for All, the faith in government you have. I mean, let's face it, the pandemic has exposed an awful lot. Our response of the pandemic was largely driven by government agencies. Agencies I would say have been corrupted and captured by big pharma. There's not one therapy, there's not one vaccine that is generic, that's been recommended. Everything's either, the novel, patentable drugs starting about $500 for Paxlovid, $700 for Molnupiravir, $3,500 for Remdesivir, okay? But this cornucopia of widely available generic drugs was ignored. And how many times have we talked about early treatment? Get in there early. And yet, NIH guidelines today, get tested and do nothing. Go home afraid. We not only ignored our agencies, the government not only ignored early treatment, they sabotaged it. And I don't see how anybody can take a look at our response to the government response to this pandemic. 1 million people dead. The human toll, the economic devastation of these ill-advised, widespread shutdowns that didn't work. What we've done to our children, how anybody could say that was a success. It's been a miserable failure. So why in the world would anybody want to put government more in charge of healthcare? Let's properly diagnose the problem by just looking at history. Okay? 1940, 80 cents of every dollar was paid for by the consumer. We had consumerism in healthcare. What's happened since then is now you got government paying for 55%, insurance paying for 35%, and the consumer only pays for a dime out of every dollar spent in healthcare. Now, I come from the private sector. I would have loved to have been a monopolist, but because I wasn't, my prices were a lot lower, my quality was a lot higher, as was my customer service. That's what the free market provides. The lowest possible cost, the best possible level of quality, and customer service. We need to introduce consumerism. We got to reintroduce the discipline of the free marketplace. Having government take it over will not do that. Ms. Turner, I want to ask a question. One of the reasons people do like Medicare is because it is heavily subsidized, not just by government payments, but by the private sector, correct? The cost sharing makes our hospital systems actually work, because oftentimes, certainly with Medicaid and Medicare, they're not reimbursed even for their costs. So talk about that cost sharing and how that would all go away, and all of a sudden government care for all would not look that pretty.
Private health coverage, both primarily through employers, but also through private plans, pay higher rates in order to get hospital care, physician care for their members. And those higher rates are what allow hospitals and physician practices to actually keep their doors open. I had a physician friend in Florida who said that he wanted to take Medicaid patients, and he did. And he had a patient with complicated lung problems. He said, ordinarily, private health insurance would pay me $750 for this course of care. When he got his check from Medicaid, the check was for 6 cents. He said, how many Medicaid patients can I afford to see when I get those kind of reimbursement levels?
You know, I think another issue is, as I've talked to hospitals and people coming in during the pandemic, and now that those rules that were suspended, you know, things on telemedicine, which makes sense. That's a market-driven innovation, right? All of a sudden, you won't be able to practice telemedicine. So all the innovations that we're able to implement during the pandemic to relieve the healthcare system of the bureaucratic rules. I mean, again, those of you pushing Medicare for all, what makes you think there will be lower bureaucracy with government-run healthcare? There will be greater bureaucracy, greater rules, more regulations, less innovation, and higher costs. Would you agree with that, Ms. Turner?
And even less transparency. I agree with Dr. El-Sayed that we need to have much more transparency. That $4.4 trillion are sloshing through our healthcare system, and so few people feel they have control over that spending, and that they can make a decision to get the best care at the lowest price from quality providers. That's what we need.
I have 37 oversight letters into the agencies covering a wide range of subjects in terms of this mismanagement of the pandemic. I've gotten almost zero responses because the health agencies have not been honest, they have not been transparent. And so again, to think government is going to be more transparent, that it's going to be more efficient, that the health is going to, all of a sudden, everything is going to be coming up roses, I think is complete misdiagnosis of what a possible solution might be. Thank you, Mr. Chairman.
Thank you. Senator Scott.
I want to thank everybody for being here today. I grew up in a country where a kid like me, growing up in public housing, born to a single mom, could go out and try anything because it was a capitalistic system that created opportunities for us. We had to get a good education. You had to work hard. I started working at 7. My family, we all worked hard, and we were able to achieve the dream. Right now, if you look at what's going on in this country right now, let's look at where the economy is right now. Today, PPI numbers came out, 11%. Look at the inflation numbers up, over 8%. Look at our GDP, it's negative. You can't think about it. In the United States of America, you can't get baby formula if you're a young mom. I've talked to young moms that had to drive around all weekend last week and try to get baby formula for their kids. So we have a supply chain crisis. We've got interest rates going up. We got the stock market going down. So this socialist agenda that the Democrats are pushing, it's not working. You can't spend money you don't have. We have $30 trillion of debt. Medicare is going bankrupt. Social Security is going bankrupt. We're not pre-funding any programs in this country. There was a bill that got passed that put Medicare actually in a worse position. We moved retiree benefits from the Postal Service to Medicare when we know Medicare is not funded. So now we're talking about Medicare for all, which I think it ought to be called Medicare for none. The bill that we're talking about today will abolish the current Medicare. Here's what we're talking about. Abolish the current Medicare program and make private insurance illegal. Think about that. The goal is to make private insurance illegal. They don't want to widely expand government. They want to make it illegal to have your private health insurance. We ought to just all read the bill and understand exactly what's happened. So the horrible proposal will ruin the Medicare program because right now, as you know, it's not funded, right? And we're running $1 trillion+ deficits. The Biden agenda takes our debt to $45 trillion. Tell me how we're going to pay the interest expense on what we already have. It's going to throw 150 million people off the private insurance program. Over 24 million people have Medicare Advantage programs, which they like because they get additional benefits. That's gone. According to independent estimates, it will cost upwards of $30 trillion over the next 10 years. I don't know where the money is coming from. So, one, it makes private insurance illegal. It lets government decide what procedures you get, when you get to have them, which ones are covered, which ones you get to have. You want the government to make these choices for you. It pays doctors less, healthcare workers significantly less. We already have a worker shortage. You pay people less, guess what? You're going to get fewer of them. So if you care about healthcare for this country, it doesn't make any sense at all. So, Ms. Turner, advocates of Medicare for All keep using UK and Canada as examples of great socialized healthcare. Can you talk about the problems of wait times in the UK or Canada and how it impacts somebody's individual health?
Well, and as you say, because of a resource shortage, people wind up with long waiting times. The Fraser Institute in Canada has been studying wait times for 30 years. When they started, the average wait time from seeing a practitioner to getting referred to a specialist and getting your treatment was about 9 weeks. It's now 26 weeks, half a year, and in some areas it's a year. In the UK has so many people on waiting lists for care that the UK Health Secretary says if you spent more than 18 months on the waiting list, then you can go to a private payer in order to get care. But it's not just there. Any place where you see resource constraints, and that's absolutely what will have to happen with the government-run healthcare system. In California, health officials just announced that fines for $55 million, Mr. Padilla's home state, the Los Angeles County government, for low-income residents treatment plan. They found that people were having to wait an average of 90 days, which is 6 times longer than the 15-day limit. So it happens anywhere that you have global budgets and resource constraints and are not able to pay enough people and not have enough facilities to provide the care. Universal coverage does not mean universal care.
No, you don't get it. So take the UK. If you're rich, do you have to go through the UK system? No, there's a separate system. For the rich, they can go to private hospitals. Right. So if you're poor, you have to wait. Wait if you get the care in time to stay alive. Right. But if you're rich, you can either go to the UK or you actually come to the United States, which like a lot of Canadians come to the United States. Right. So what this will do is if you want care for everybody, this will mean you'll get way less care for people, and you'll wait longer for your care. Thank you.
Thank you, Senator Scott. Welcome back, Chairman Sanders.
Thanks, my apologies for having to run. It's a kind of a party line vote, and it's a 50-50 Senate, so every vote matters. Let me just take the opportunity to ask a couple of more questions. Under an employer-based healthcare system, does anybody have a guess as to how many people are staying at their jobs today, not because they enjoy their jobs or feel productive in their jobs, but because they see work right now as the only way they can get decent healthcare coverage? Any thoughts on that? I see some hands in the audience. Dr. Syed, is that something you've thought about?
Absolutely something I've thought about. It's hard to get an estimate of that simply because job markets are in such flux and people's preferences are complex. Although, I think about the impact, and frankly, the CBO has thought about these things too, the impact on the economy. Our Republican colleagues love to talk about what's good for the economy. And you think about the impact of the economy on all the businesses that go unbuilt, all of the new careers that go unestablished because people are worried about what might happen if they leave their job and lose their health insurance. On top of that, small businesses, almost every single small business owner you talk to, and you ask them, what are your biggest challenges? They'll rate, according to survey after survey, health insurance for their employers as one of the worst. And so it's hard to pitch a counterfactual in terms of numbers, but it's important for us to ask, what would be the effect if you didn't have to worry about that, doing that entrepreneurial thing, that thing that America is supposed to be known for, that would mean you and your family losing the health insurance in the process?
Anybody else want to respond to that? Ms. Turner?
Senator, employers try so hard, and they get beat up on because they really are trying hard to find good health insurance as affordable as possible for their employees. And actually, a study by the Heritage Foundation found that 5.7 million more people had coverage in December of 2020, a year into the pandemic, than did in 2019. So employers tried very hard to keep their employees on the payroll as much as they could. They also, many people went into the ACA. So there are safety nets.
No, I don't think that's a question of beating. I hope nobody here, I don't think, is beating up on small business. I think the point that Dr. El-Sayed was making, and I remember this as being a mayor, we had the same problem as any small business. We had to search for the best, most cost-effective health insurance. We spent an enormous amount of time and money trying to figure it out. And what I think is not well known is that what single payer, what Medicare for All will do is take that burden off of small business, because all of their employees will have quality health care, and they can maybe go about their business of doing what they do rather than spending so much time and energy on worrying about how they can get affordable health care.
If I may, Mr. Chairman, far from beating up on small business owners, the question I keep asking is, what would make it easier to be a small business owner? And I think taking off the mental space that goes into asking, how do I make sure that my employers are covered today, would make it far easier to focus on whatever the business is. But it's not just small business. It's also big business. I'm from Metro Detroit, where during the Great Recession, the automotive bailout was the single most important question on everybody's mind. And one of the big questions was, how do we pay for private health insurance, not just for employees, but for retirees at GM? And what ended up happening is a number of the jobs that would have stayed in the United States actually got offshored to Canada because folks could get their health insurance paid for. It wasn't a line item off the top of every employee that you had to employ. And so, these questions are dogging businesses, whether large or small, in this country. And if we're serious about investing in our economy, taking the overhead of having to think about healthcare for every single employee you have off the top of business decisions, I think would be pro-growth and pro-economic empowerment in this country.
Let me ask another question. We don't talk about, it's generally speaking, the more important the issue is, the less we talk about it. In our nation, our life expectancy is shorter than most other industrialized countries. But even within our nation, there is a huge disparity in life expectancy. I read an article somewhere that in southern West Virginia, which is 5 hours away by car from Fairfax, Virginia, southern West Virginia, very poor, Fairfax rather wealthy, life expectancy for males, I think, was something like 15 years. Why is there such, and right here in Washington, D.C., depending on which part of the city you live in, the life expectancy will be significant. Why is that so? Thoughts? Dr. Gaffney?
Well, obviously, health is more than a reflection of medical care alone. And I think that speaks to the gross inequality in our society that affects people in terms of their housing, in terms of their exposure to COVID-19, for that matter, in terms of occupational safety, in terms of exposure to pollution. But I do think medical care matters a great deal in these inequalities. And we know that because, researchers, you can look at life expectancy, but you can always also look at something called treatable mortality, which is deaths that we think are preventable through medical care. And if you compare, for instance, a country like Canada to the United States in its treatable mortality, they have about half of the treatable mortality as us. So the fact of the matter is that we need to fix a lot in our society to rectify the kinds of gross inequalities you're describing. But a big part of that is fixing our medical care system to make it accessible, to make it universal, and to make sure that people can have access to the best care regardless of their race, ethnicity, or income.
If I can build on what Dr. Gaffney shared, if you think about the way we calculate life expectancy, you think about the contribution of every life on average. The lives that contribute the most to reducing our life expectancy are the lives that are lost the earliest, and those are the babies that pass. And you think about keeping a baby alive, that's a real complex question because you're talking about two lives. You're talking about the life of the person that bore that baby, and you're talking about the life of that baby themselves. I was a health director in the city of Detroit. We had one of the highest infant mortality rates in the entire country. We were also the poorest city in America. Those two things are not unrelated.
If I recall, those infant mortality rates are not dissimilar from some really poor third world countries. Is that correct?
Across our country, our infant mortality rate is not dissimilar from very poor lower income countries. But in Detroit in particular, yes. My family comes from Egypt. I had a grandmother who lost 2 infants before the age of 1 from among 8 to whom she gave birth. She had a personal infant mortality rate of 25%. And the crazy thing is that I would go to Egypt when I was a kid. I'd go 15 hours. I could go 15 minutes from where I grew up in Detroit and go to a place where the infant mortality rate was quite similar to where it was in Egypt. And so if we're serious about investing, and I know my colleagues, my conservative colleagues here, care a lot about the lives of children, they say. And if we're serious about that, then what we would make sure is that every single mother had health insurance, regardless of her circumstances, so that she could access prenatal care services, that every single baby, right, would have the basic services it needed should it fall ill. But too often in cities like Detroit, because we had hospitals go from being public hospitals to being nonprofits to being finally for-profits, where they're constantly asking, how can I skimp $1 out of Medicaid because it's such a low-income community? Too many people, in effect, get locked out because of the churn of trying to stay on Medicaid at that moment where they're trying to safely bear a child and bring it to life. And so if we're serious about the well-being of infants, if we're serious about our life expectancy, then we ought to be serious about making sure that that transition into life is done with the full investment in health care for that mother and that baby.
Good, thanks. I see Senator Braun is here. Senator Braun?
Thank you, Chairman Sanders, for letting me be able to speak. I had a lot of stuff going on. I'm glad we convened this because I come from Indiana, viewed healthcare as the most important benefit. My own employees ran a company for 37 years, and probably the proudest thing I did was covered pre-existing conditions and no caps on coverage, and turned my employees into healthcare consumers along the way. So what Senator Sanders is talking about in Medicare for All is because we've got a broken healthcare industry. I've fought with it in trying to get good coverage for my own employees. And there's 2 things in life, generally, when you're spending money. You got to aspire to what you know is a need and then do it in a way that's affordable. Ironically, all other countries haven't found a way to get the markets to work. And that's why you have them doing something that is either a 2-tiered system or what Senator Sanders is talking about. I personally think that we could cascade into that. And I talked to a lot of CEOs, most of whom never took it as seriously as I did, brought it into the C-suite. And I tell you what we accomplished. We cut costs by close to 50%. And you normally think, well, that means people weren't getting covered. No, they were getting covered, and along with doing it, I removed the co-insurance part of insurance to where outside of my employee's deductible, they're never going to go broke because they get sick or have a bad accident. That should be the attitude of every company. When you're not taking care of things in the private sector, you're going to look to government to do it. Whether that's the eventual thing that happens here remains to be seen. I'd love to see the healthcare industry actually reform itself, embrace transparency, embrace competition, embrace educating a healthcare consumer, and see if you can take cost out of the system before government ends up paying for it, or to where you got a broken health insurance system increasingly dominated by huge corporations that even when you're a decent-sized company like mine, you can't even wrestle with them. So it's either going to be a solution that the problem generators fix by embracing competition, embracing transparency, knowing that healthcare, along with education, are the two most important things for families. Ironically, they're the two most expensive things in our system. And when that happens, government gets more involved. I think that we need to converge from two different directions. I think Medicare for All will win the day, and it's a solution that most other countries had to go to some version of. But I think we've got the possibility of keeping the unique best things about our healthcare system, but it's going to be totally up to the big hospital corporations, big health insurance, even practitioners to embrace transparency, give healthcare consumers choice, and pharma, which gets a lot of the blame, they deserve it. They do an excellent job on the R&D, and then they come up with some monstrosity, middleman, that sucks out billions and billions of dollars that keeps insulin high. So it's broken in almost every facet. There is entrepreneurialism happening. In Indiana, a clinic was started by some anesthesiologists, cuts the red tape of government and big corporations. Give this example, a gallbladder operation. In our state, the negotiated rate is $18,000. And the surgeon, whoever's doing the work, gets paid a very, very small amount of it. If you're uninsured, but you could afford it, it's going to cost you $32,000. They're going to do it for $8,000. That is the kind of restructuring we need, and it needs to be the providers of health care. Insurance should almost be out of the question. The pool for insurance would be all Americans. And it ought to be easy like that because it's the number one most important thing, especially as you age. And sadly, too, we've got work to do here within our own government. The programs that depend elderly, especially those that can't afford insurance, Medicare and Medicaid, going the wrong direction, not sustainably. I really don't have a question because I've been working on this so long. I just want to let you know that you can have two different points of view, but we ought to at least agree on the problem that healthcare as we know it is not accessible to enough people. It sends too many people to bankruptcy court. And if the people that run these big entities now don't do something about it, they shouldn't have anyone to complain to because government will be the solution. I think if we did do some legislation that forced transparency, competition, they say they're free market, let's do it. It would make government-provided health care less expensive. And maybe we could take it from 20% of our GDP down to 12 and have our cake and eat it too. The way it looks, they are so intransigent. I've been speaking about it. I don't know if they'll accept changing themselves. that would be a better solution, and we ought to probably try to work on a few ways to do that as well. Thanks for listening.
Senator Braun, thanks very much. Well, let me just thank the panel. We've kept you here for a very long time. But I appreciate all of the work that all of our panelists are doing, and as Senator Braun indicated, there's probably no issue more important to the American people than health care. So thank you all very much. Our next panelist is going to be the Director of the Congressional Budget Office, Director Phil Schweigel. Thank you. Dr. Schweigel is going to be with us virtually. He is the Director of the Congressional Budget Office, a position he has held since 2019. Previously, he was a professor at the University of Maryland School of Public Policy and a visiting scholar at the American Enterprise Institute and the Milken Institute. Dr. Schweigel has served as Assistant Secretary for Economic Policy at the Treasury Department and as Chief of Staff and Senior Economist at the White House Council of Economic Advisors. Dr. Schweigel, thanks very much for being with us.
Thank you, Chairman Sanders. Chairman Sanders, Ranking Member Graham, and members of the committee, thank you for inviting CBO to testify about single-payer healthcare systems based on the Medicare fee-for-service program. I'm testifying by video because I have a little time yet in isolation. I'm fine, and I look forward to emerging. I'm joined today by my colleagues Chapin White and Jeff Kling, and I'm grateful to Chairman Sanders, to your committee staff, for arranging this remote testimony. So CBO has analyzed 5 options illustrating the effects of differences in providers' payment rates, patients' cost sharing, and the system's coverage of long-term services and supports. The system proposed by Chairman Sanders in S1129, the Medicare for All Act of 2019, is like these 5 options in some ways and different in some others. We haven't analyzed S1119 in particular. CBO found the following effects relative to what would occur under current law. So federal subsidies for healthcare in 2030 would be significantly larger, with increases in subsidies from $1.5 trillion to $3 trillion, depending on the option. National health expenditures would change by amounts ranging from a decrease of $0.7 trillion to an increase of $0.3 trillion, again, depending on the system's design features. The most important factors tending to reduce national health expenditures are lower payment rates for providers and reductions in payers' administrative spending. Conversely, the most important factor tending to increase expenditures is increased use of care. And that's especially if long-term services and supports are a covered benefit, as is the case in one of our 5 options. So health insurance coverage would increase, with virtually all U.S. residents covered by health insurance. Total out-of-pocket costs would also be lower. The supply of health care would increase because of fewer restrictions on utilization, less money and time spent by providers on administration, and providers' responses to increased demand for care. The amount of care used would rise, and in that sense, overall access to care would be greater in the single-payer systems we analyze. The increase in demand for health care would exceed the increase in supply in our analysis, resulting in greater unmet demand than under current law. So higher overall access to care and increased unmet demand would occur simultaneously because people would use more care and would have used even more had it been supplied. But the increase in unmet care, the increase in unmet demand for care would correspond to increased congestion in the healthcare system. That would mean more delays in foregone care. Now, turning to the economic effects, I will describe the outcomes under the 5 options that CBO analyzed if the system was financed by either a payroll tax or an income tax. And the estimates on those economic effects depend on the type of tax used for financing. So our projections for the effects relative to what would occur under current law are as follows. Gross domestic product, GDP, would be approximately 1 to 10% lower by 2030, and aggregate non-health consumption per capita would change by amounts ranging from an increase of 3% to a decline of 7%. lifetime non-health consumption would rise among lower income households and decline among higher income households. And the number of lifetime hours people choose to work would be lower for most households across the income distribution. The net reductions in GDP occur primarily because of the effects of the increased taxes on labor and capital income. If the system was financed by other types of taxes, by government borrowing, or reductions in other types of government spending, the net effect on the economy and of course, the distributional implications would be different. In addition to the effects of the system's financing, other effects would occur, and these are other economic effects. For example, workers would see increased taxable wages as employers would no longer provide health care benefits and would pass along those savings to employees. That's again through higher cash wages. And higher longevity and labor productivity would result with the improvements in health care. So CBO has published a series of reports and working papers underlying the summary I've provided today in the written testimony. My colleagues and I would be happy to talk about the details of that analysis and to answer any questions. Thank you very much.
Well, Dr. Schweigel, thanks very much for being here, and thanks very much for all of your work, and we hope you get well quickly. In December 2020, CBO released a 209-page working paper on single-payer healthcare. CBO considered 5 options of moving to a single-payer system and found that in 4 out of the 5 scenarios, a single-payer program would save the American people between $42 billion and $743 billion a year, beginning in 2030. The option that most resembles the Medicare for All bill that I introduced, which is option 3, would save the healthcare system $650 billion a year, beginning in 2030, while covering every man, woman, and child in our country with no premiums, no deductibles, and no co-payments. So, Dr. Schweigel, am I correct in stating that option 3, which is the option most closest to what I have introduced, would save $650 billion a year beginning in 2030?
Yes, sir, Mr. Chairman. National health expenditure would go down by $650 billion in 2030 in option 3. That has the lower payments to providers, lower cost sharing, has long-term services and supports, what's in Medicaid, but not beyond what's currently in Medicaid.
Speak a bit about the nature of administrative savings. How does a Medicare for All move closer to what other countries spend on administration? How much are we spending now compared to what we would spend on the Medicare for All?
Okay. And I might ask my colleagues to jump in with additional details as well. So option 3, which is the one that you had mentioned before, would result in a $414 billion reduction in administrative costs. And there'd be additional $508 billion savings from changes in the payments to providers. The administrative costs would be on 2 sides, right? Both on the provider side, that with a single payer system and essentially universal coverage, providers such as doctors and hospitals would spend much less time. This is figuring out the sorts of things they figure out now with insurance companies. So that's on the provider side there. And
let me ask you this, if I could. I'm sorry to interrupt you, but I don't know if you have it in your top of your head right now. What does Medicare spend on administration compared to the private health insurance industry right now?
Chafin, do you have that off the top of your head about the
Sure.
Oh, that'd be great. Thank you.
In our analysis, the Medicare fee-for-service program had administrative expenses of about 2.3%. Compared to private insurers, which were more in the range of around 12%.
And there are some, obviously, private insurance companies that spend a lot more than 12%. But I hope everybody understands what we're talking about. The goal of healthcare is to put doctors and nurses and healthcare professionals into contact with patients. Administration is the buffer in between. That's shuffling papers. And what we're talking about now is, according to the CBO, on average, the private sector spends about 12%, Medicare spends 2.3%. You add that to the entire healthcare system, we're talking about hundreds of billions of dollars in savings. Not to mention, I don't know, Dr. Schweigel, I don't know how you quantify this, But I think people throughout this country go crazy in trying to argue with insurance companies about what they're entitled to and why they were covered or why they weren't covered. Are there any economic analyses as to what that costs in terms of the amount of time the American people have to spend in arguing with insurance companies?
So we looked carefully at the experience of the literature in the US, and we looked at the experience of other countries such as Canada at those savings. And that's our lower administrative costs. As you say, there'd be immense savings, both from the provider side and for families. And that would result in more care. This is the time freed up by those administrative savings would mean more time providing care to beneficiaries.
Well, let's talk a little bit about prescription drugs and the savings that would incur in a Medicare for All. I believe, and the American people overwhelmingly believe, that Medicare should negotiate prescription drug prices, and the fact that we don't do that is the reason that we pay by far the highest prices in the world for our medicine right now. Do you have estimates about how much Medicare for All would save through prescription drug negotiations with the industry?
So we do have lower savings from negotiated prescription drug costs. Again, I'm sorry, I don't have that off the top of my head. Chapin, do you remember the
It
dollar
depends.
savings?
Yeah, it depends on the specification. We had a higher payment scenario and a set of lower payment scenarios. And in the lower payment scenarios, prices for prescription drugs would be about 27% lower than under current law. But the volume of prescription drugs used would be higher because of lower cost sharing, and so total spending on prescription drugs would go down under either of those scenarios.
Okay. Now, one of the reasons that Medicare for All is expensive is because it does what should be done, and that is make sure that every American has health care, provides quality care to all of our people. How many more people, what in your judgment, it would be the impact in terms of accessibility to health care for a Medicare for All system? How many more people would be getting health care who today simply cannot afford to get that?
So under the single payer system, virtually all people residing in the U.S. would be covered. This would mean improved access to care, and importantly, be for both those who are uninsured under current law in 2030 and those who are insured. People, even those who would be insured, would have access to greater networks and lower out-of-pocket costs, and therefore would use more health care. So, and of course, for people who would be uninsured, that would be even a bigger difference in terms of their access and lower costs.
Has the CBO done any work in taking a look at what the impact on the economy would be if all Americans were guaranteed health care and would no longer have to stay at a job that they did not want to stay in just because they got good health care at that job? Is that something you guys have looked at?
It is, and we've put out a report going through the macroeconomic effects of the advent of the single payer system, as well as the financing that I mentioned in the opening remarks. There'd be many economic effects. One I mentioned was increased cash wages as employers shifted the.
Well, let me stop you. What that means right
please.
now, that employers spend a whole lot of money providing health care to their employees, and without having to do that, there would be the opportunity to pay their workers higher wages, correct?
That's exactly right. And there'd be other effects. It'd be greater job mobility, which I think was mentioned in the earlier
Talk
panel.
about that job mobility. Do you have any guess? I know this is a hard question and nobody will have an exact answer, but I go all over the country and talk to people who say, I'm on my job, not because I really want to be it. I want to do something different. My wife is ill and I've got good health care coverage right now. Can't afford to leave that job. Do you have any sense how many people we're talking about who are at their job for health care and what it would mean to the economy if they were able to do what they wanted to do and retain health care for their family?
Okay, I'll give an initial answer, and then my colleagues can jump in. There is, solid economic evidence for this, the phenomenon of job lock, and that reducing that would increase mobility, increase choices for families, but also increase entrepreneurship, and that would increase productivity and economic growth. I don't know the quantification offhand, but maybe my colleagues do. But the evidence is pretty solid there.
Yeah, I think the CBO's assessment is that people do tend to stay in jobs longer, and it's a phenomenon called job lock. That our assessment is that phenomenon is real, but we haven't quantified the number of people or the effects of increased job mobility on GDP or earnings.
But we are in agreement that if everybody in this country were guaranteed comprehensive health care, people would be freer to leave their jobs and do what they really wanted to do. Is we in agreement on that?
That's right, and that would boost productivity and entrepreneurship.
Okay. All right, that's about it for me, and I don't see any of my colleagues here. So, Dr. Schweigel and your team, let me thank you all for the very important work you have done on this issue. Thanks very much.
Thank you, Mr. Chairman.
Before we close, I would like to ask unanimous consent that a statement for the record by Egan Camp, healthcare policy advocate as public citizen, be entered into the hearing record, and without objection, that will happen. Let me just again thank all of the witnesses here, as well as Dr. Schweigel and his team, for being with us. Look, this debate is, in my view, maybe the most important debate facing our country. And I just want to thank all of you for the work you are doing and have done, and I know will do. As information for all senators, questions for the record are due by 12 noon tomorrow, with signed hard copies delivered to the committee clerk in Dirksen 624. Email copies will also be accepted under our rules. The witnesses will have 7 days from receipt of our questions to respond with answers. With no further business before the committee, this hearing is adjourned. Thank you all.